Now we'll go to the second case presentation, which I'll be presenting now. Uh, A 25-year-old married female patient came to us with pain and swelling in the hands, wrist, elbows and knees since 5 years. She had early morning stiffness for 2 to 3 hours. She was taking painkillers almost every day and was able to manage her day-to-day activities, but since 1 year, she is not being relieved even with them. She doesn't have psoriasis, no evidence of enthesitis, no other CTD features. She doesn't have any similar history in the family also, no other significant past history. She is P2L2. She was on oral steroids for a month in the beginning of this year, which she stopped due to facial puffiness. She has also tried various alternative therapies. She came to us after being referred by her primary care physician on 15th of September. On examination, she is moderately built and nourished, well-oriented. Vitals are normal. On joint assessment, she has got tenderness in 8 PIP joints, 8 MCP joints, 2 wrist joints, both the elbows and both the knees. So totally she has got 22 tender joints. And she has got swelling in 6 PIPs, 4 MCPs, both the wrists, elbows and knees. So totally 16 swollen joints. She has already developed deformities. She has got swan neck deformity in the right index and middle finger, restriction of movement in both the wrists, flexion deformity in both the elbows, and visual analog scale, pain scale is 8 on 10. So she was thoroughly investigated. CBC showed hemoglobin a bit low at 9.2, total count 5,600 with a normal differential count. ESR was high at 90 millimeter at the end of 1 hour. Peripheral smear showed normocytic normochromic anemia, probably anemia of chronic disease. CRP was high at 26 milligram per liter. LFT renal function tests were all normal. She had a rheumatoid factor of 130 units per liter and anti-CCP was also strongly positive. Other viral markers were negative. So X-ray of the hands showed juxta-articular osteopenia with erosions. So this is juxta-articular osteopenia, which is seen even in early rheumatoid arthritis, and she has also developed erosions in various joints in the wrist as well as MCP joints and few PIP joints. X-ray of the knees and elbows were normal. So diagnosis in this patient is it's a clear-cut case of seropositive rheumatoid arthritis. So assessment of her disease activity was done by using the DAS-28 score, which we have already learned in the morning sessions. So, and as Dr. Vishnuvardhan sir was telling, we can also calculate the DAS-28 score using various internet this thing. So, and these are the formulas for DAS-28. High disease activity is when the score is more than 5.1. Low disease activity when the score is less than 3.2, and patient is said to be in remission when the score is less than 2.6. So in this patient, DAS-28 using ESR was 7, and using CRP it was 6. So it indicated high disease activity. So initially she was managed with DMARDs and steroids. As we know, DMARDs will take at least 4 to 6 weeks to give a response. So initially she was given a depot shot of methylprednisolone 160 mg stat, and she was also started on methotrexate of 10 milligram a week along with hydroxychloroquine 400 mg a day. NSAIDs initially. She was also advised to go to physiotherapy. Counseling was done because it is going to be a chronic disease. She has already developed deformities. We have to tell her to strictly adhere to the medications. And she was called back after 4 weeks. This was second visit. So when she came back to us, her joint pains had reduced by 30%, but she was still not able to carry out her activities of daily living. ESR was 62, CRP 16, had reduced from the last visit, but still high. She had not developed any side effects due to the DMARDs because counts, LFT, RFT were all normal. Pain scale had reduced to 5. she still had some tender and swollen joints. So her DAS 28 score by ESR CRP still showed a high disease activity, though there was significant improvement in ESR CRP total tender and swollen joint count. So if we plot a graph, so we can see that all the parameters had reduced from the first visit. CRP had drastically dropped. Other parameters, tender joint, swollen joint, the score had all come down to, but not normal, had reduced. So now what to do? I'd like to have some inputs from the audience as well. What would you like to do at the second visit? After 4 weeks, patient has come with reduction in the symptoms. DAS 28 is still showing high disease activity.
I think any input from the audience would be appreciated before expert speaks on that. Anybody?
This is an interactive session. I request the audience to give their views on this.
What would you love to do with these patients? Options are 3. Number 1, to continue medicine, reduce the medications, or increase the medications. A, B, C. Pardon? Reduce the? Pardon? No, she's not on steroids. She was only given a shot of depomedrol. Pardon? Increase the medications. Opinions? Yeah.
Yeah. See, when you have seen the initial slides, before starting a patient of a rheumatoid arthritis, we should get a mental picture of what the patient should be or will behave to you. Frankly speaking, I will expect the same result before starting the drug also. I think that is the usual response. Usually people respond like this only. This is the usual way how this. The reason is a young female, high ESR and CRP with lot of tender and swollen joints, early deformities, early erosions which are documented so clearly on X-ray in a very short span. These are all a very good recipe for a very poor prognostic long-term course actually. So this is a case of a severe early rheumatoid arthritis with poor prognostic factors. So mentally, even if the patient improves considerably, I would have hiked up the drugs as the option C actually. And the anemia at that time is nothing but anemia of chronic disease. That is the reason why we have to hit the inflammation to get the HB up. So that is why despite having moderate anemia, methotrexate was started. Now since the DAS score, if you calculate the DAS score again, it will be moderate disease activity.
So it's still high, sir.
High
still
only,
high.
still high, it will be HDA. So my personal choice, the CB is normal. So maybe HB might be more than 10 or 11. So we should shift to parenteral methotrexate along with a combination. This is my personal choice.
Dharma?
See, on the same lines like Dr. Vishnu, this is a poor prognostic rheumatoid arthritis from the beginning. From the day one, we have not seen unfortunately we have not seen the patient at a very early stage. So we are seeing them after a year or so. So she is a poor prognostic rheumatoid arthritis. There is a role for starting her on 3 DMRDs, like a triple DMRD therapy with a short course of steroid, either oral or parenteral. So one choice is to start methotrexate, same 10 mg per week, hydroxychloroquine 400 mg per day, and also sulfasalazine simultaneously. This choice sometimes varies. Sometimes you can either start 2 or 3, but never 1 in these patients. So always 2 or more DMRDs and a few courses of steroids, either depomedrol 160, maybe second visit we will give her 120, then third visit 80 to control the disease quickly, and while allowing the methotrexate and other DMRDs to act. So this is an aggressive RA. We have to do everything to control the disease as quickly as possible.
Yeah, I mean, I think the best option is to increase the DMRs either by adding one or increasing the current present disease modifying anti-rheumatic drugs.
So we increased the dose of methotrexate to 15 mg per week. We continued hydroxychloroquine. We gave her another shot of steroids because she was still not able to carry out our day-to-day activities. And we of course encouraged her to do exercises and physiotherapy, which has to be continued. She came again after 4 weeks. Pain was better by 50%. Tender joints and swollen joints had reduced. Visual analog scale was 4. ESR, CRP had reduced. Now the disease was showing moderate activity. So this is the graph which we can plot at the end of 3 visits, at the end of the 3rd visit. So again we continued to increase the dose of methotrexate, continued hydroxychloroquine and NSAIDs, SOS. She came for the 4th visit. She was 90% better, and she had come to near remission as per DAS ESR and under remission as per DAS CRP. So it was showing a drastic improvement in all her parameters. We further increased the dose of methotrexate to 25 mg per week and continued hydroxyquine. So this is the state after 6 months. She has already gone into remission. Now what to do? Whether to continue the same medications, reduce the medications, stop the medications.
Any inputs? Any views from the audience?
Reduce to maintenance level. which
So
we
you would
have
love to
continued.
start tapering the dose.
We will, ideally we would love to reduce the medicine, but if you taper it too rapidly, too early, then disease is more likely to bounce back. So the moment a good remission is achieved, we would love to continue the same dosage for at least 6 months. So if the patient remains at this DAS score for another 6 months, then we can start thinking of lowering the dose. If you drop it now, it is very, very possible that next time when they come, she will come with a DAS score of 4.2 or something like that. So she would very likely to bounce back. So sustain the improvement for 6 months to 1 year before you start tapering the disease modifying drugs. So we would probably continue that.
It's audible? It's audible or?
Continue the drug at a full therapeutic dose for another 6 months before we start tapering the dose. So we won't do it in a hurry unless there is a side effect. If the patient shows LFT of say 60, SGOT, SGPT of 60 or 70, then probably we would reduce it to be on the safer side. If the bloods are normal, the patient is tolerating the drug, we will keep at the same dosage for another 6 months minimum, maybe up to a year before we start tapering.
Yeah, actually, we should never stop a drug once we got a remission. Until 6 months to 1 year, the patient is still a ticking time bomb, despite with this dose. And 25 milligram methotrexate is a very safe dose, provided we are monitoring the patient every 3 months actually. And the second important thing is, at the back of the mind, always we should see that this patient has early poor prognostic factors. That nature will never go. Only the disease status has decreased because of our drugs now. So thinking that the disease has gone into remission, even if we pull the trigger of getting the drugs down, then immediately she will relapse and again she will need the whole exercise again.
I think let me draw the analogy of what I was talking hitherto. See, I think we are all well versed in handling the diabetes. I think what is expected from you in a patient when you give a diabetic medication or antihypertensive is that once you normalize the diabetic sugar level or once you normalize the blood pressure, you are not going to reduce the dose. What are you going to do is you are going to maintain the patient in the same dose. What triggers you to bring down the blood pressure antihypertensives or the diabetic medication is he going to hypotension or hypoglycemia. Unfortunately, when it comes to rheumatic disease, we don't have a hypoglycemia or hypotension kind of situations. The problem for us is mainly the adverse reactions. And currently, as we stand now, we don't have a marker which tells us that the patient has gone to some state of what we call as a permanent or a long-lasting remission. So that's why it is presumed that, as I was saying in the very first opening statement I said, we need to manage a rheumatic disease as a chronic disease, not as an acute disease. That's the reason why I brought all these cases for the discussions. What we do in an acute case, the moment the phenomena is gone, we are going to pull off the medications. In a chronic disease, what we do is, the moment the disease is come under control, You stop escalating the dose, but you maintain the dose. The message is the time you achieve the target, the remission, what we talk about 2.6 or 2.8, you need to maintain the patient at this dose. If I go to the recommendation, there are no current recommendation even in rheumatoid arthritis for withdrawing the drugs or reducing the dosage. The recommendation says maintain at the minimum dose where the patient is in a persisting remission, which should at least be 6 months to 2 years, but I personally go up to 1.5 to 2 years, the same status of whatever the dose, patient continues to maintain the remission. Then think of withdrawing with the clear note to the patient, you may relapse at any time. So with that note you need to bring in and think of tapering subsequently. So we need to get away from the acute model of managing rheumatic disease, especially rheumatoid and lupus and other connective tissue diseases. You need to bring in a targeted disease activity state which is close to normal, maintain it as we do in any other chronic disease. Well, we know very well what we do in diabetes and hypertension. The moment you get the normalization, you maintain the dose. And that's what we recommend here for 2 years, or worst scenario if they develop an adverse reaction. Methotrexate is quite a very safe drug. I can tell you the side effect of diclofenac if you given for 1 year vis-a-vis the adverse reaction of methotrexate given for the 1 year, the difference is 100 times. It's not 1 time, the 100 times. Hepatotoxicity, renal toxicity is 100 times higher in diclofenac sodium compared to the methotrexate. It's quite a safe drug. Unfortunately, it is like drinking a Coca-Cola in a liquor shop. It is, brand has come as an oncology drug. The name that it's an oncology drug fears and scares all of us. All the adverse reaction listed on that particular medication is at a dose of 1 gram to 2 grams per day, what an oncologist pump in to kill the malignant cells. What we are giving is hardly around 25 milligram once a week. And I still use the word, it's hardly any amount of methotrexate what we are giving. And actually if you see, earlier it used to be recommended to do a bone marrow, the liver biopsy after 3 years of medications, and to do a fibroscan after 3 years of medication, all been withdrawn, because now they are very clear that all these adverse reactions are more hype than what it really occurs. So we don't do liver biopsies, we don't do any of those. What we need is a regular monitoring for SGOT, SGPT, blood count, albumin. If you do these 3 measures, you will be able to monitor most of the adverse reaction which can happen. It's relatively less. I can tell you it's very, very less. One shot, single shot. Preferably it should be given as a single shot. Only in an unusual circumstance where patient do not tolerate the 25 mg given at 1 pulse, you can split it into 10 and 25, but it is preferable to give as a single dose. There are various studies which has yeses and nos. Probably if you are getting hand on to my book on methotrexate, it has answered all these questions with reference to methotrexate. I think one of the stall was giving it actually. You can go through, I have answered all these questions about 1 pulse, 2 pulse, how to modify, alter the methotrexate dosing schedules. It's a very wonderful drug.
Yeah, because we are quite used to giving 5 milligram in 3 split doses over the last so many years.
That
We
has
still
come.
continue that.
That has come from dermatology studies. Initial studies used that dosage. Now, as Chandrasekhar was trying to tell, giving a single bolus dose is supposed to achieve a good therapeutic concentration. So even if you are splitting, we don't split it beyond single day. If you 25 milligram, I'll split 12.5 in the morning, 12.5 in the evening. So there is some studies say above 15 milligram, 20 milligram oral absorption may not be adequate. So we can split. Some people do split. I do split. Chandrasekhar doesn't split. But both of us got equal results. So it seemed to work. And don't take it to the 3rd day, 4th day. So taking it on the same day is supposed to be more effective and less toxic.
Side effects are less if it's given in single pulse.
One important thing in monitoring methotrexate is when you get a SGOT or SGPT of 60 on methotrexate, it is a knee-jerk reaction to stop the drug actually.
That's very.
Please don't stop the drug when you have a SGOT or SGPT of 55, 60, 45 or just above the upper limit of normal. Unless it is elevated more than 2 times, don't take a call. And usually I take a cutoff of 90 to 100, but I do closely follow them. It is a hint to closely follow him, but not to stop at around 55 or 60 of SGOT or SGPT. Actually, in a patient with the patient or rheumatoid arthritis, patient can be on steroids, patient can be on painkillers, and patient could have a fatty liver inherently. There are multiple causes actually. So a 60 of SGOT PT immediately we can't ascribe to methotrexate. But however, we will be cautious and we will be monitoring them more closely, but not stopping the drug.
Not stop or reduce. Neither of that is not required.
So for this patient, it was like a dream come true. Within 6 months, she achieved DAS remission. She had been suffering from the disease since last 5 years. So she was doing well. And this is the graph which shows she was advised to continue the same dose of methotrexate. She came back after 2 months. So this time her pain had increased and she had few swollen joints. Her tender joints had increased to 14, swollen joints were 8. The VA scale was 7. Other TC was 12,000. ESR had gone up to 90, CRP to 15. She again went into the category of high disease activity. So now what could be the reason for this? So this was the graph which is showing that she was this is what happens with most of the rheumatoid arthritis patients. Initially they seem to respond quite well, but sometimes they just flare up. And there can be various scenarios why this could have been happened. She could be non-compliant because she had responded quite well, she's doing well, so she might have stopped the medications in between. Or probably she was compliant with the medications, but still she had a flare in her disease activity. Or probably there was something else along with her arthritis. So I'd like to discuss all the 3 scenarios. I'd like our chairpersons to discuss all the 3 scenarios and how to manage them.
So the first scenario, non-compliance with medication. Yes, definitely we will ask them to get back to our medications. But in this case, along with coming back to the older medications, I would like to add a low to moderate short course of oral prednisolone or methylprednisolone, slowly taper off. And by the time another 6 weeks, if she is non-compliant, the drug will start acting again and she'll come back to or bounce back to the normal state.
Yeah, I mean, that's the best option. Either you can give a shot of depomedrol or a small short course of oral steroids. Resume back to the drug. So once you have made point clear probably that there are 2 ways things would have gone wrong because she has discontinued the medication or irregular on the medication. The dose at which she may be going to benefit may be the same. So maintain the same dose, watch for next 6 weeks. She may come back to the normal. So the one possibility is she comes back to normal. The relapse could be because of discontinuation of the medicine. These are the patients who may have to go through a round of counseling, talk to them a little more closely, tell them, explain them this is what happened to you, explain them why she should continue, and also you should explain this is where your measure helps. If you show them the graph, this is what has happened, it really impresses the patient. See, I told you in the very beginning why these measures are required is to communicate between ourselves and to the patients. Patients should know that discontinuing the medicine was responsible factor for the relapse. And this is what has triggered back the things. And if this happens repeatedly, you may land up with the deformities down the lane. These issues can be ascertained when you have a measurement. You can tell anybody to say that move this by 10 inch. So rather than telling it, move it, where to move? So the question comes is where to move, how much to move. So if you give it with a number, with a precision of a measurement, things become easy for the fellow who communicate and the fellow who receives it. And that's where the measures are likely to help you in our day-to-day practice.
The compliance issue is very, very important. It is not uncommon for the patients to stop the drug. Particularly when somebody is on 25 milligram methotrexate, goes home, so some relatives come and tell, oh, you are on some heavy dose of medicine, they'll stop. They go to the general practitioner well-meaningly, no, methotrexate is always given at 7.5, your doctor is giving high dose. So these are the situations. I can't blame them because their knowledge level somewhere is stuck at 7.5 milligram, which was very popular in 10 years back. So well-meaningly, I'm not blaming them, well-meaningly, they put these words to the patient's ears at the moment the patient reduces the dose or stop the dose and come back. So the compliance issue is a major issue. So patients will be scared to tell us that they have stopped the medicine. They'll say, no, I'm taking. So if you dig in, I will not feel angry, please tell. Then said, once in a while I stop, sir, once in a while I... So that is very, very important to ascertain. If that is the case, that is the best scenario. We know that giving a depomedrol, we can again control the disease, continue the same dose, we need not do anything more. If the second situation is the issue, the patient has taken very reliably, her husband vouches for it, he has brought it, it has been spent, there's no extra strips of tablets left at home, then we are into trouble. This is a poor prognostic patient, temporarily improved, again it has broken through. So we are going to have a problem with this patient. Then we may have to put her on a low dose steroid or consider adding another DMRD like leflunomide or sulfasalazine to achieve a control. So it becomes a problem patient. So that is a most difficult situation. At some point of time, these are the patients who might require biologicals in the future. And the third scenario is again a good scenario. Lot of infections like urinary tract infection, viral infections can cause a temporary increase in cytokines and immune system goes for a spin for a temporarily. It is able to break through the control of methotrexate and again show a spike. So this can be again managed with a very short course of steroid or a single dose of depomedrol. They come down and they again remain well. So the first and third scenario are easy to deal with. The second scenario is tough. So we are in for trouble with this patient because if they are not responded well to 25 milligram methotrexate, we are really stuck. There is a good evidence that majority of the patients who don't respond well to this dose of methotrexate are unlikely to respond to another DMRD, like sulfasalazine or leflunomide. So there is some literature evidence. Somebody who has failed 25, very unlikely to achieve a remission. Only a small percentage, 2 to 3%, 5%, we can achieve a remission. So these are the patients who might ultimately go in for biologicals if they can afford.
Yeah, I mean, see, this is what we normally face, and this is where the scoring and a clinical judgment. In a sense, what we are trying to say is, bounce in disease activity, we need to reanalyze. See, this is the same thing what we do when it comes to the diabetes mellitus. So I can tell you, a patient who is regularly on OHA, whose GHP is good and well, who skips the tablet, what we do is, you put him back to the same tablet where he was earlier and ask him to continue. And if the patient gets an urinary tract infection, transiently sugar control goes haywire. And what we do at that time is, if necessary, temporarily you introduce an insulin and then switch back him to the OHA as it is required. And in a in a compliant patients whose OHA is failing, what we call as a secondary OHA failure, there we are going to go for moving into the another OHA, or you are going to switch over to insulin. This is the same scene what we have practiced with a chronic management, and this is what we expect it with reference to the rheumatology or rheumatic diseases, but you need to know what on which basis you are doing or taking this call.
I can add the same analogy. See, we all fear methotrexate. So methotrexate still remains since 1940s. It's not withdrawn by FDA. But quite a few diabetic drugs which looked innocuous,
Pioglitazone.
for rosiglitazone,
Which is there back.
we all used it. That have gone with the major side effects. So some of the so-called innocuous looking, benign looking drugs can be much more serious than a malignant looking methotrexate at a low dose. So low dose methotrexate is not the methotrexate we learned in pharmacology books.